Okay, so I'm back. We're going to talk about the contraindications for the lumbar spine for pelvic traction for the practical exam. So again, we're just kind of consolidating the ones we just talked about. So again, there's pregnancy, hiatal hernia, osteoporosis, fracture, a medial disc derangement that's been confirmed by an MRI, cancer, claustrophobia, and joint hypermobility or instability. Precautions for the lumbar spine for pelvic traction for practical exam would be a history of spinal surgery, spondylolysis or listhesis, and breathing difficulties. Contraindications specific to the cervical spine for a practical exam would be an acute injury to the head, neck, or spine, connective tissue disorders such as rheumatoid arthritis, Down syndrome, or Marfan's, which you have just issues with instability, osteoporotic bones, steroid use for prolonged time. Again, we talked about that when you've had prolonged steroid use, that thins your bones and makes you more susceptible to being osteoporotic and to having fractures. Cancer, osteoporosis in the advanced stages, and the patient's unable to lie supine. Precautions for cervical spine traction for the practical exam would be any kind of temporomandibular joint dysfunction, along with dentures. So most cervical traction now uses an occipital halter versus one that used to be go over the jaw and would cause issues with the temporomandibular joint, or if the person didn't have their dentures in, it increases that space in there and that can cause issues. So if someone has dentures, you just want to ask to make sure, ask them if they have dentures and that they have them in, and then I would use the occipital halter on both these cases. And just a special note, you want to make sure on the evaluation that you saw somewhere that that physical therapist did test for the alar ligament and the vertebral artery prior to ordering any kind of cervical spinal traction, because those obviously you're going to cause some instability and you could cause some serious issues. So you always want to make sure you look back on that physical therapist evaluation to make sure that they have those marked, that they tested those. And if they don't have them marked, you want to go communicate with them before you apply the traction to the patient, because they may have done it and just forgot to mark it, or they may have forgot to test it, and you're going to want to make sure they test that prior to you administering cervical traction on them. Okay? So this is a really nice diagram that is in your camera book that explains the difference between a lateral versus a medial disc protrusion and why a medial disc protrusion is a contraindication for traction. So here we can see, here is that lateral disc protrusion, and it's compressing that L4 nerve root, because here's L4, so that's how we name it, coming out of L4, and it's putting some compression on there, probably causing some radicular symptoms and some low back pain. So we do the traction. And we can see with that traction, it opens up this disc space here, but also that nerve root moves medially. So can you see that? So how it was here, and now that nerve root moved medially, so that's taking pressure off of that disc protrusion there and relieving some of that pain. So this is where a lateral disc protrusion traction is very effective with. And now let's go over to the picture C here. So now that disc protrusion is medially and versus laterally of that nerve root at L4. So now can you imagine when you go to do that traction, we still get that separation here, but remember that nerve root goes medially with traction. So when it goes medially with traction, it's actually increasing the nerve compression on that medial disc protrusion, exacerbating their symptoms, and this is why it's a contraindication to do traction on a medial disc protrusion. Okay. Then we'll talk about the other adverse effects. So we all know about the rebound effect. We've been talking about that all semester long. So also with traction, we can imagine that you can get a rebound will increase the pain after initial application of a high force traction. So you want to think about different things you can do to try and avoid that rebound effect. We know with the initial treatment, you want to keep it low force, and you're going to gradually increase it within the recommended range to the point of maximum benefit for that patient. With this, you need to remember, you have that hold relax time. So most research had showed, so let's say you're going to do, I'm going to use the example that Paulo and Lindsay had on their video and kind of just do a little correction on one of the settings that they did. So they had that Lindsay was 120 pounds. They wanted to use 50% of her body weight, and it was, so that would have been 60 pounds, but he decided since it was her first time, he was going to start with 50 pounds which was totally appropriate. And then, so you have that as the maximum, and then under the minimum, he puts 0. So that means that every time that she has that hold, it's going to go for 50 pounds, but then it's going to go all the way down to 0 for her rest cycle. So you can have ramp up and ramp down just like you do with electrical stimulation, but most of the studies show that you want that minimum amount to be about 50% of the maximum. So we would want, if she's at 50, we want that minimum to be somewhere around 25. That's going to help eliminate that rebound effect. So it's going to say somewhere in that 25 to 50 range the whole time. You still, if they're having more severe pain, you're probably going to have more ramp up and ramp down times with them so that it's a gradual progression to that 50 pounds and a gradual regression to that 25-pound minimum to avoid that rebound effect. And then we also have them lie on the table for about 5 minutes after the traction before we have them get up. So those are all a couple different things that we do to help that patient not get that rebound effect after traction.